Good evening, everyone. Welcome to the Africa Healthcare Network Fireside Chat Series 212. It is both a privilege and a profound honor for me to introduce a nephrologist, teacher, researcher, and a visionary who has dedicated more than 4.5 decades to advancing the science and practice of kidney care, Dr. Mohan Manohar Rajapurkar. Dr. Rajapurkar has been a pillar of excellence at the Muljibhai Patel Urological Hospital in Nadiad, Gujarat, India, where he has served with distinction for over 45 years. During this remarkable journey, he has held several key leadership roles, including medical director, head of the Department of Nephrology, and director of postgraduate studies and research. Through these roles, he has helped shape the institution into one of the most respected centers for kidney care and training in India. His contributions to medicine have been recognized with some of the highest honors in the field. Among them is the prestigious Dr. Bidhan Chandra Roy National Award in 2007, one of India's most distinguished recognitions for medical excellence. More recently, he was honored with the International Society of Nephrology Pioneer Award of Southeast Asia region in 2023, acknowledging his transformative impact on kidney care and education. In 2025, he received a Lifetime Achievement Award from the Indian Society of Nephrology, further celebrating a career that has profoundly influenced generations of physicians and nephrologists. Dr. Rajapurkar's academic legacy is equally extraordinary. He has authored influential chapters in the globally respected textbook Seldin and Giebisch, The Kidney, contributing to areas such as nephropathy, kidney transplantation, dialysis, and catalytic iron. His research spans critical topics including chronic kidney disease epidemiology, oxidative stress, dialysis, and transplantation. His work has been published in leading journals such as the Journal of American Society of Nephrology, Kidney International, and the Clinical Nephrology, helping shape modern understanding and management of kidney disease worldwide. And beyond scholarship, he has also been an innovator. Dr. Rajapurkar holds United States and European patents related to early detection and treatment of adverse cardiac events, demonstrating his commitment to translating scientific insight into practical solutions that improve patient outcomes. On the global stage, he has delivered numerous prestigious orations, fostered international collaborations in kidney health, and played a pioneering role in establishing interventional nephrology in India, expanding the scope and impact of the specialty. And yet, beyond those awards, publications, and innovations, those who know him best recognize another dimension of his legacy, his role as a mentor. He has guided and inspired countless students, young physicians, and helping shape many wonderful careers in nephrology and beyond. And his trainees, with great affection and respect, fondly call him MMR, sir. I consider myself deeply fortunate to have been one of those students. The lessons that I have learned from him about medicine, integrity, curiosity, and compassion continue to guide me in my professional journey, and I carry out his teachings with me to this day. It is therefore my great pleasure and honor to invite to the stage a true pioneer of nephrology, an inspiring teacher, and a remarkable human being, Dr. Mohan Manohar Rajapurkar. He will be speaking to us tonight on serum catalytic iron, a novel biomarker of acute and chronic tissue injury in kidney and heart disease, a marker of ferroptosis. Sir, it is my great pleasure. Welcome, sir.
Thank you very much, Amar, for this very, very kind introduction. I bring greetings to all of you who have joined for this webinar, and thank Amar and Dr. Lloyd for inviting me to this Africa Healthcare Network. Most of us think of iron only as a hemoglobin producing thing, but iron is extremely important, and life is impossible without iron. It is a highly abundant element, essential for life on Earth, and integral to various biological processes. It originated from stellar nucleosynthesis, where during the Big Bang, two nuclei, the helium, lithium, and hydrogen were first produced. And with their fusion, particularly in supernovae type 1a, produced iron used for planetary formation. Iron has unique redox properties, allowing electron transfer between ferrous or Fe2 to ferric ion states, enable its vital role in oxygen transport, cellular respiration, DNA synthesis and replication and repair, as well as epigenetic, transcriptional, and translational gene regulatory mechanisms, and in several metabolic pathways. The prevalence of insoluble ferric iron under aerobic condition limits iron's bioavailability. Moreover, iron's reactivity poses further challenges. The unshielded iron can undergo redox cycling, leading to oxidative stress. Thus, all biological systems have evolved in such a way that iron acquisition, utilization, storage, these mechanisms ensure that iron remains bioavailable. However, it is covered and related with a bigger molecule to prevent its toxicity. Now, if you look at the relative abundance of inorganic elements which have biological functions, you can see iron is one of the most important transitional metals, and you can take sodium, magnesium, aluminum, which all of us know that these metals play a vital role in our. So, iron is the largest transitional metal in the earth crust. However, it is not present in the ocean. It's believed that if you increase the iron content of ocean, you will actually produce more plankton, and which will then absorb carbon dioxide. And that's one method of reducing the carbon exposure. Iron is useful physiologically for oxygen transport storage. I've already said that. I started my research journey and when we developed a renal sister center relationship with the University of Arkansas. The International Society of Nephrology that time had announced this sister center program, which still continues in the International Society. At that time, it was advertised in the Kidney International, and Professor Tom Andreoli, the person on the right side here, was the professor at University of Arkansas. I had applied to few friends whom I knew, but all of them refused that they were already busy. So I wrote to Andreoli thinking I'll get no response. But to my surprise, he immediately responded that the chief of the division of nephrology in Arkansas would be happy to work with you. And that was Sudhir Shah. Professor Sudhir Shah has, to his credit, a lot of original work in oxidant systems, particularly catalytic ion. And that is how our journey began in 1991. He had shown in multiple animal models that oxidants are important in kidney injury, both in glomerulonephritis as well as non-proliferative glomerulonephritis. And that chelating ion in those animal models mitigates injury. He was looking for doing human work. That is where we decided to work together. When I told that to my father, who was a pharmacologist, that I'm going to work on free iron, he said, oh, here is, he was very happy because he had already published adrenergic blocking action of ferrous iron way back in 1960s. So it runs in family, as they say. Iron, as I said, is ubiquitously distributed in biology. Most of the iron exists as bound to macromolecules like hemoglobin, ferritin, transferrin, and several other iron-containing proteins, the cytochrome 450 for that matter. Very small amount exists as unbound. We call it labile or catalytic form. This is responsible for catalyzing the oxidant reaction. Labile or catalytic ion pool has been described by Richard Crichton, a doyen of inorganic biochemistry iron, as somewhat like the Loch Ness monster, only to disappear from view before its presence or indeed its nature can be confirmed. Now, I've brought out here, you have got a cascade of free oxygen radicals and that are ion mediated. And these have to be balanced by glutathione and the antioxidant and scavenging systems. And this balance has to be very critically managed. Now, it was Fenton first observed in 1894 that a simple mixture of hydrogen peroxide and Fe2 produces hydroxyl radical. That's the equation one, Fe2 plus H2O2, Fe3 plus OH minus. Now, in the presence of trace amounts of iron, superoxide can then reduce Fe3 to molecular oxygen and Fe2. The sum of this reaction, some of these reaction is called Fenton reaction and produces molecular oxygen plus hydroxyl radical and hydroxyl anion from superoxide and hydrogen peroxide in the presence of catalytic amounts of iron, the so-called Haber-Weiss reaction. So oxygen superoxide and hydrogen peroxide produces free radicals. This superoxide is a free radical, finally water. And this is the Fenton chemistry. Now this ion that in very trace amounts is responsible for carrying out this reaction in biological system. How do you measure this amount? The property of bleomycin detectable ion is measured by using an assay based on the formation of bleomycin ion complex, which then reacts with DNA, resulting in DNA degradation. Now, this is the way in which bleomycin works as an anti-cancer drug. The DNA degradation products, namely malondialdehyde, is measured with a thyrobarbituric acid reaction. And the intensity of color that is developed is measured in a spectrophotometer at 532 nanometers against a blank. So the bleomycin only binds to free ion. It does not bind to any other ion, and therefore this reaction measures only ion which is unbound. And unbound ion is a state because the ion moves from Fe2 to Fe3 and vice versa, depending on the situation, of which pH is probably one of the most important. And this assay very much relies on having a precise pH of 7.4 to 7.6. Now, if you diluted FeCl3 as a standard in a strong acid, you produce a standard graph. So as the FeCl3 concentration goes up, your standard graph goes up, the A532 nanometer measurement, OD goes up, but as the assay is constant only between 1 to 10 micromoles per liter, and then it actually falls off. Whereas if you use an alkaline Chilex treated water to remove all iron, FeCl3, then it produces a very slow rise and it's not very good. This is how it was described in the original assay published by Guttridge and Halliwell, where they used only this portion of the standard graph to measure iron in the experiments that they did. What we did was to modify the assay in such a way that it is reproducible and you can run multiple batches. So what we did was we made a standard solution of high concentration of FeCl3 in 20 normal hydrochloric acid, and then kept on diluting it serially to achieve 0.11, 10, 100, and 1000 micromoles per liter in a pH, because you diluted it with a very alkaline water, a Chilex treated water. Chilex resin removes any iron from existing contamination in the water. So when you dilute this very acidic solution of ferric chloride, what happens is that you achieve a final pH at these concentrations to have a completely soluble standard in the assay. Now we measured we did a plotted standard graph every month by the same solutions we had made, and measured their coefficient of variation. And for 6 months, we did that. The coefficient of variation of intra and inter-assay measurements of serum was 3.4 and 1.22. Whereas the same, when you measured it for urine, came to be 15%. Now, this is because if you have urine standing on the lab bench, it changes its pH. Carbon dioxide evaporates, urea gets converted to ammonia, and therefore the pH changes. As the pH changes, the iron at a low pH is bound, whereas at a high pH, it gets dissociated. That is why probably in ICU, acidosis releases iron from its bound proteins, such as transferrin. So we measured within run and total standard deviation of modified bleomycin detectable iron by the evaluation. So we ran 2 replicate samples per run and 2 runs per day for 20 days. And then we measured the coefficient of variation, which for a biochemical assay we found to be very, very accurate. Now, then we tried to see what happens if you add desferoxamine to the sample and try to measure very higher and higher amounts of desferoxamine was added to the serum assay. And you can see it progressively lowered the catalytic ion in the solution. And same thing if you added desferoxamine to the standard solution itself. Again, it proved that the assay is quite valid and precise. Now, if you looked at, so all right, you did a good method of measuring free ion, but what good is it for clinical things? Now, if that is the major element which controls oxidation, and a lot of diseases we think, like atherosclerosis, like endothelial injuries, or injury due to many pathological processes, whether immunologic as well as non-immunologic, have a final common pathway of producing tissue injury is mediated by free ion. If that is true, we thought, let us see whether this catalytic ion is associated with cardiovascular disease. So in a cross-sectional study of 496 participants, we had 85 who had known cardiovascular disease. Catalytic ion was measured by that method of ours. The odds of existing CVD for persons in the upper third of catalytic ion was 10 times that of the persons having lower catalytic ion in unadjusted analysis. After adjusting for age and Framingham risk score, estimated GFR, hypertension status, high density lipoprotein, cholesterol, systemic blood pressure, and associated, the association remained significant. The odds ratio was 3.8. In conclusion, we provide a preliminary evidence for a strong detrimental association between high serum catalytic ion and cardiovascular disease, even after adjusting for several comorbid factors. This is shown in this table it published. So unadjusted, the odds ratio is 10 times more of having cardiovascular disease. If you adjust only for age and gender, you get an odds ratio of 4.9. And when you add everything for complete, it still remains 3.8, which is very statistically very significant. Then we asked ourselves, will serum catalytic ion is significantly associated with the presence of acute myocardial infarction in patients presenting in emergency or suspected of acute coronary syndrome? So we designed a study to 178 consecutive patients who presented in the emergency room of suspected acute coronary syndrome. All patients received standard of care. Serum samples were collected at presentation and at 24 hours and transported under dry ice to my lab, had to be stored at -70°C. This was done in Vadodara, which is about 55 kilometers from our place. And it was analyzed for various ion parameters, including catalytic ion. 250 healthy controls were served as controls. Healthy volunteers served as controls. Out of these 178, 127 were accurately identified by our biomarker as acute coronary syndrome. And acute coronary syndrome was proved by a highly sensitive troponin I and changes in the electrocardiogram. Now, if you looked at controls, their mean catalytic ion at admission was 0.1 micromole per liter. Those who were suspected but they did not have AMI had a catalytic ion of 0.2 plus minus 0.16, and those who had acute MI had 1.5, so which is about 10 times more. So these are the box plots showing that. Now, if you plotted a receiver operator curve, now if you looked at a catalytic ion level of 0.3 to 3.5 micromoles per liter, the sensitivity of the diagnosis of acute myocardial infarction was 84%, specificity was 95%, positive predictive value of 87%, a negative predictive value of 93%, and an overall accuracy of 92%. We also found that those patients, the mortality had much higher catalytic ion compared to those who did not have mortality, the infarction, stent thrombosis, and a composite endpoint of all this. Also, those who had a composite endpoint had a mean catalytic ion of 3.23 versus Those who did not have any of these composite endpoints is 0.05. So again, it proved a very strong association. We also followed those patients for 30 days and found that odds ratio for the predictor of catalytic iron was significantly associated with the major adverse cardiac events after acute coronary syndrome. This was published in a relatively obscure journal called Eurointervention. We faced about 7 rejections from various prestigious journals that time. That was a big learning curve for me, simply because I kept on persisting from one journal to another. One time came when I thought I should give up, but finally it got published in this journal. Then we thought that doing our patients who have the highest risk of cardiovascular disease, patients on maintenance hemodialysis. Let us look at them. So cardiovascular disease, as you know, is a leading cause of morbidity and mortality in maintenance hemodialysis patients. 59 end-stage CKD patients stable on maintenance hemodialysis volunteered to do this study, join this study. All patients underwent coronary angiography and the serum samples were collected for catalytic iron. And more than 70% obstructive coronary artery disease was present in 37% out of these 59, all of them being asymptomatic for cardiovascular disease. And this 70% obstruction was measured by a automated formula on the cath lab. It was not an observation by the cardiologist, but actually measured. So 37% had coronary artery disease. These are the typical patients. You have diabetes who have higher cardiovascular disease, hypertension, tobacco abuse, family history. All these were taken into consideration. Now, if you looked at the controls, that is 0.11, normal people who have no CKD, no comorbidities, whereas those who are on maintenance hemodialysis have a high catalytic iron. So if you took all maintenance hemodialysis, even amongst that, those who did not have coronary artery disease had a much lesser catalytic iron compared to those who had coronary artery disease. Among the diabetics, those who had coronary artery disease had a very high catalytic iron. Those who didn't have coronary artery disease, though more than the normal population, still had high coronary catalytic iron. Now, if you looked at the multiple regression analysis, these patients the catalytic iron was significantly associated with cardiovascular disease. Diabetes was significantly associated with, though diabetes and catalytic iron proved to be significantly associated with the presence of cardiovascular disease in patients on hemodialysis, and the cardiovascular disease proven by a coronary artery angiogram. So we measured timed average constant of catalytic iron over a period of 1 year and tried to plotted a curve of those iron quartiles 1 to 3 had significantly less events, cardiovascular events, as compared to those who had highest quartile of catalytic iron and were significantly associated. So if you're exposed to catalytic iron, the chances of getting cardiovascular events are high. You can see that high catalytic iron, 50% at the end of 2 years were no more. They had a cardiovascular event. So then we thought that, well, these are studies we have done, but to conduct a large clinical trial requires a lot of money. So we decided to go to already established biobanks of well-known studies, like this TIMI study. So we designed a sub-study with the main proponents of the TIMI study, Dylan Steed and Christopher Cannon. We measured catalytic iron patients with acute coronary syndromes from this study. So we got these samples which were preserved for 1,701 patients who had unstable angina, non-STEMI and STEMI, who were followed up for a median of 10 months. All endpoints were educated by a blinded clinical endpoints committee. So the samples came to Nadia we measured catalytic iron, and the statistics and the results were calculated in Boston. We found that Kaplan-Meier events rate up to 10-month follow-up. If we looked at this is the number of patients in quartile 1, quartile 2, 3, and 4. Now, these are interquartile ranges of catalytic iron. Now, if you looked at all-cause mortality in these 10 months, the highest quartile has the highest mortality and a very significant p-value, which is not so with myocardial infarction, ischemia leading to urgent revascularization, hospitalization, stroke, composite endpoints. But catalytic iron was very definitely associated with mortality. This is the first time we realized that. And then when we adjusted by a multivariate analysis, again we found that the odds ratio of dying in these patients over a 10-month period was about four times that of other quartiles. So if you have a high catalytic iron, you're doomed for a highest risk in spite of multivariate adjustments for many things like age, diabetes, prior MI, prior CHF, ST deviation, creatinine clearance, NT-proBNP, current smoking, KIDIP class. You adjust it for every other thing, you still have a odds ratio of 4 in the fourth quartile, highest quartile of catalytic iron. Now this translates to a mortality which starts becoming higher than all others in the first month after infarction. That's the quartile 4. So we said, let us do an Indian study of acute myocardial infarction who are undergoing radioiodinated contrast for a PCI. So at admission and after coronary intervention and for the first 1 month, we followed these patients and measured their catalytic ions. There were 6 centers involved, 806 patients were enrolled. Patients in Baroda, Ahmedabad, Surat, Nagpur, Hyderabad, and Pune. And the samples were transported to us. Now, change in catalytic iron from baseline to 48 hours in patients who developed contrast-induced nephropathy, defined by the standard KDIGO method, and those with no contrast-induced nephropathy, median and interquartile ranges is given here. Now, creatinine, those who did not have contrast-induced nephropathy at baseline was 0.91 in these patients. And those who later developed, these two were not significantly different. Whereas at 24 hours, those who had contrast-induced nephropathy, the creatinine had doubled, and at 48 hours it had increased, an increase of 94%. Now, if you looked at catalytic iron, those who developed contrast-induced nephropathy had a significantly increased catalytic iron from baseline. The baseline also was higher than that of normal population. And at 48 hours again, those who developed contrast-induced nephropathy had significantly higher. So those who did not have contrast-induced nephropathy, the percentage rise was about 3%, whereas it was 27%, 9 times more catalytic iron in those who developed contrast-induced nephropathy. If we did adverse cardiac events of baseline catalytic iron, mortality was significantly associated with quartile 4. And the trend was also significant. Now, adverse cardiac events like as the quartile 1 to 3 versus quartile 4, because we thought the quartile 1 to 3 was not very much different from each other. So we combined quartile 1 to 3 and compared it with quartile 4. We found that it was very significantly associated with mortality in these patients. When we did those who developed contrast-induced nephropathy had higher death rate, 9.1% versus 1%. Again, very significant. So if you develop contrast-induced nephropathy, or if you had a higher catalytic iron, you have a higher chance of dying after acute coronary syndrome. And if you did multivariate analysis for this, multiple adjustments, again you found an odds ratio of 7.99, very significantly associated mortality, or a composite of all the things, mortality, MI, heart failure, contrast-induced nephropathy. That was the composite. So you can see the mortality in Q4 versus Q1, 2, 3. And in those who got CIN, again, it showed similar. So contrast-induced nephropathy, this has been shown in animals also, that you have contrast-induced nephropathy, you have a higher chance of getting AKI. So then we associated ourselves with Professor David Leaf at Boston and Boston and Women's Hospital, Brigham and Women's Hospital. Sorry. We found the patients with immediate acute kidney injury and death following cardiac surgery. So we had 250 patients with an age of around 79, 43%. 43 was the mean age for women. We had multiple comorbid. These are the baseline characteristics of that cohort. We measured catalytic iron, cell-free hemoglobin, total iron, transferrin saturation, ferritin, and urinary NGAL to creatinine ratio. Type of procedure, 31 had CABG, 100 in valve surgery, CABG plus valve in 78, elective and cross-clamp time. And what did we find? That we found the primary endpoint is here. Pre-op day 1, end of cardiopulmonary bypass, catalytic ions, odds ratio, and their intervals. We found that ferritin, NGAL, and catalytic ion were significantly associated, and not others. Free hemoglobin was appearing towards significance, but it did not. Neither total ion, nor transferrin, nor ferritin were associated strongly with mortality. Now, if you looked at the association with adverse events, unadjusted analysis showed 6.62 odds ratio of need for renal replacement or death in this cohort of cardiac surgery patient. And if you adjusted it, it still was 6.71. AKI significantly associated. Hospital mortality significantly associated. 1 year mortality was not very significantly associated. So basically, it predicted adverse cardiac events if you have high catalytic iron. So these are the bar charts between those who did not require renal replacement and survived, whereas those who needed renal replacement and had death. So at end of cardiopulmonary bypass compared to pre-op, if there's such a tremendous rise, you will get a higher chance. And the higher catalytic ion continued to, on postoperative day 1 and postoperative day 3, also predicted the presence of the possibility of getting death or needing renal replacement. So if these are 3 different models, figures: renal replacement, AKI, hospital mortality, 1 year mortality. Here again, these are the highest quartile, gives you the highest mortality and need for renal replacement. So acute heart and acute kidney injury. Now, what happens in critically ill patients? Again, we looked at 121 critically ill patients admitted to intensive care units between 2008 and 2012 in Boston. The plasma, catalytic iron, free hemoglobin, all other iron markers were measured on ICU day 1 and day 4. The primary endpoint was hospital mortality, AKI requiring a RRT. Secondary endpoints included mortality, hospitalized 1 year, and incident AKI defined by KDIGO. Among critically ill patients, elevated plasma catalytic ion levels on arrival to the correlated with mortality. These are the baseline characteristics. You have 62 years as the mean age, 46% women. Renal function at enrollment was okay. There were comorbidities, hypertension, chronic lung disease, active malignancy, diabetes, CKD. Surgical ICU, non-surgical ICU, other procedure, surgical patients, elective or urgent. And so all this was calculated. And we found that those patients who had death or needed renal replacement in ICU had a much higher catalytic ion as compared to other patients on day 1 as well as day 4. Now, if you did a plasma catalytic ion day 1, and adverse outcomes. In unadjusted analysis, around 3 was the odds ratio, which was quite significant. And after adjusting, it still remained 3.3. So in study after study, we are finding that death and RRT are associated with highest quartile of catalytic iron after adjusting for many factors. Same thing in graphs, death and RRT. And if you look at AKI, based on the number of quartiles, first, second, and third quartile, this is tertile, therefore 3 graphs, you find that higher catalytic iron is associated with higher mortality. Higher catalytic iron is also associated with higher stage of acute kidney injury. So it is proportional to the amount of injury produced. Then we undertook a study with the University of Leipzig with Professor George Forneau from the cardiogenic shock study. The aortic intra-aortic balloon pump shock 2 trial was already published. So we assessed the biobank for samples. And in this IIBP shock 2 study, 185 of these patients whose blood samples were systematically collected at baseline and day 3. Catalytic iron was measured, several other iron parameters like free hemoglobin, total iron binding capacity, ferritin. Hepcidin was also measured, transferrin saturation. Patients at baseline catalytic iron in highest quartile had a worse outcomes in comparison to patients with lower catalytic iron. Hazard ratio 1.91. On day 3, the hazard ratio was 2.08. So in conclusion, we found that the catalytic iron levels were associated with increased short-term mortality in cardiogenic shock complicating acute myocardial infarction. High levels of catalytic iron at day 3 were associated with bleeding and high troponin levels in these patients. Now, if you looked at it this way, that 30-day mortality, hazard ratio, catalytic iron quartile 1 and quartile 3 at baseline. And on day 3, again, you find the same kind of a situation in most of these studies. Then we looked at a cohort of 806 study participants in an AKI trial network study. And 409, that is, there was 51% death, died by day 60. Catalytic iron levels in highest quartiles versus lowest quartiles had 4-fold increased risk of death in the patients with hepcidin levels in the lowest quartile versus highest quartiles of hepcidin had 3.87-fold, which means they behave exactly opposite. As the catalytic iron goes up, the hepcidin is protective, whereas catalytic iron creates a problem. In model 1, it is unadjusted. Even unadjusted, the catalytic iron in quintile here in the model, which is unadjusted, is significantly high mortality. When you adjust for demographics and comorbidities, and when you do it for full model, and the hepcidin, highest hepcidin is more protective, and lowest hepcidin is not protective from death and AKI in these patients of AKI, severe AKI. These are all severe AKI, all of them needing renal replacement therapy in ICU. The same thing is shown of catalytic iron and hepcidin with mortality. Highest quartile of catalytic iron produced less and less survival, and the lowest quartile of hepcidin was again associated with greater mortality or lesser survival. This was the graphic abstract in JASN of this study. Now we looked at catalytic iron is significant. This was the thing we thought, that if catalytic iron is so associated, then its exposure should be similar to that of progression of chronic kidney disease. So the hypothesis was catalytic iron is significantly associated with progression and major adverse kidney events in patients with mild to moderate chronic kidney disease. So this is a sub-study of the Indian CKD cohort study conducted by Professor Vivekanand Jha. This is the graphic abstract. 2002 patients, mean GFR 41 ml, median follow-up 12.6 months, major adverse cardiac events Which are the major adverse composite of kidney replacement therapy? More than 40% decline of eGFR and death due to kidney disease. This is the major adverse. Now, if you take a cutoff of 0.3 micromoles per liter of serum catalytic ion, you have a significant association with so strongly and independently associated with composite major adverse kidney events in patients with mild to moderate CKD. Now, we looked at that time, we were hit with COVID. The whole world was hit with COVID. And people talked of ferritin as a very important marker. Well, we looked at serum catalytic ion. And this was our hypothesis. So we did two studies, one with KEM Hospital in Pune in India, whereas another critically ill patients of COVID-19 in ICUs in Belgium with the University of Belgium, Antwerp. Two studies got published. This in India, we had 120 patients admitted to the ICU. 70 were males. The median age was 50 years. Primary composite outcome observed in 25 patients. Mechanical ventilation was needed in 21, and patients in hospital mortality occurred in 21 patients. The baseline levels of ferritin and hepcidin were significantly associated with primary composite outcome. The joint model analysis showed that ferritin levels were significantly associated with primary composite outcomes. The hazard ratio of 2.63. And after adjusting for age and gender, both ferritin and catalytic ion levels were positively associated with in-hospital mortality, or its ratio of 3.22 and 1.73. After adjusting for age and gender, the study showed association with ferritin and catalytic ion and adverse events in COVID-19. Now, if you put all these markers of iron, serum iron, measured every day. Now, blue dots are those who survived, and red are ones who died. And if you looked at log serum iron, TIBC, transferrin saturation, ferritin, hepcidin, and catalytic ion. Now, you can see it day to day in hospital mortality. The log catalytic ion keeps on going in those who died versus those who survived. The same thing you can see with ferritin. It increased, whereas in those who survived, the separation was there. Now, in the samples that we received from Belgium, we found that iron homeostasis and tendency towards higher ferroptosis, marker of malondihyde, had no association with it, except a small subset of patients with very high catalytic ion is independently associated with reduced survival. Altogether, the data point towards distinct subgroups in the cohort of critical COVID-19 patients with different systemic signatures of pyroptosis, ion ferroptosis, pneumocyte cell death, and markers that have different outcomes in ICU. The distinct groups may allow personalized treatment for allocation. Now, this was a study where multiple biomarkers were measured in the Antwerp lab, and catalytic ion was measured in our lab. And the study details were available only to the study conductors there. So we felt that the coronavirus infection leads to cell death and apoptosis. Here it should be called ferroptosis and pyroptosis, because inflammation, cytokine release, activation of macrophages and other cells leading to release and generation of catalytic ion. Hemolysis also releases iron and porphyrin. The increase of catalytic ion comes first, leading to upregulation of ferritin and hepcidin, which are markers of trying to protect. Oxidant injury and ferroptosis to several organs systems, for example, endothelium. Therefore, thrombosis was one of the common problems, and death. Multisystem organ failure. Again, with the University of Antwerp, our collaboration with Professor Tom Vandenberg, we published this in Nature Communications. Targeting ferroptosis protects. This study was done in two phases. One was a mouse model where they had their own ion chelator to show whether producing a multisystem organ failure by peritoneal cecum puncture of the mouse. And then they measured multiple markers of cell death, of which ferroptosis is important. Now, ferroptosis also happens because catalytic ion takes part in the oxidant damage which causes holes in the cell wall due to lipid peroxidation. And that lipid peroxidation also can be measured. And here again, we showed that if you looked at those, this is free ion, catalytic ion composite. As your catalytic ion increases, your SOFA score increases. Your catalytic ion is higher in those who died, sepsis, no sepsis, and shock. In shock, the catalytic ion went high. Now, similar thing was observed with the marker of MDA, which is a marker of ferroptosis. And now, if you looked at, you get two peak survival and not survival with MDA. So the maximum plasma MDA levels in critically ill patients are associated with plasma catalytic ion levels. SOFA score and mortality was the conclusion of this study. And we have written a subsequent paper also describing that many other markers in these multi-organ system failures could allow you to use specific blockers of specific processes to try and reduce mortality. However, that clinical study has not yet been done. Now, if you block the catalytic ion in the lab, I showed you a curve where the catalytic ion gets. So what we did was to use deferriprone and oral ion chelator in diabetic and non-diabetic glomerular disease. This was published in the Toxicology and Mechanism and Methods. It's a single-armed, open-labeled proof-of-concept study of safety and efficacy of oral ion chelator. In study 1, 15 patients of biopsy-proven glomerulonephritis, persistent proteinuria despite treatment steroids, cyclophosphamide, and study 2 comprised of 38 adult patients of diabetic nephropathy. Patients in study 1 were treated with deferriprone 50 mg per kg per day in 3 divided doses for 6 months. And study 2, the patients were treated for 9 months. 2 patients had severe gastrointestinal intolerance and withdrew from the study after the first dose only. We found that significant reduction, 47% reduction in 24-hour urinary protein in the first study, from 4.1 grams per and down to 1.6. There was no significant change in creatinine. In study 2 treatment, deferriprone marked persistent drop in mean albumin creatinine ratio of 187 plus minus 47 at baseline to 25 plus minus 7, a significant of stable renal function over 9 months. And there were no significant adverse events. This remained only as a proof of concept. A larger clinical study we could not do. Now, for all those juniors who are listening, if you have a really good idea, we were taught as students that perish or publish. There is a paradigm shift now. It is the present saying is perish if you publish before you patent it, so that the benefits of your research should come back to you. I was lucky to have US patents and a European patent for my biomarker. However, I'm not a good businessman. I abandoned all patents in July 25 because I had no more funding left after all this and could not develop a marketable product, a kit for measuring catalytic ion. I have no ability to manufacture, market, and provide after-sales service for the kit. That was my failure, but that does not, I would still say that those of you who have a good idea should find evidence and then patent it before you publish it. Think of this. Sudhir Shah was my mentor to begin with. All this work was done in India in my lab. Dr. Suhas Lele was the cardiologist who worked with me on many of these. And Dr. Banibrat Mukhopadhyay was the biochemist who was responsible for standardizing the catalytic ion test. We are, of course, very grateful to many of our collaborators like Professor Shishir Gang, David Leaf, Professor Steve Dylan, Professor Forno, Vivekanand Jha, Tom Vandenberge, Valentine Lobo, These were my team. I thank you for the patient listening and will be happy to answer questions. Thank you.
On behalf of everyone here, Rajapurkar sir, I would just like to thank you for this insightful and thought-provoking lecture, and how beautifully you've guided us through the history of catalytic iron, the laboratory science behind it, its clinical relevance as a biomarker in cardiovascular and renal disease, and just connecting the fundamental mechanisms with the real clinical implications truly highlights the power of translational research. The one thought that stands out is that serum catalytic iron may represent the bridge between oxidative stress that we have long recognized, and we are only beginning to understand more and potentially help us as clinicians move, from recognizing injury or to predicting it. So thank you for sharing your pioneering work and for inspiring us with such a stimulating and meaningful presentation. I would like to take this opportunity to open the floor for questions for those who are able to unmute and ask the questions. Please raise your hand and do it. For those who would prefer to type their question in the chat box, you're also welcome, and we can also unmute you should you choose to ask your question live.
Thank you very much, sir. This is a wonderful presentation. Not only presentation, bringing in this whole concept into the region. I mean, catalytic iron, with so much of effects that you see, starting from diabetes, CKD, AKI, critically ill patients, post-operative patients, infection, renal replacement therapy, and a lot more. And the thing is now, the other thing, see, in common practice, in our CKD management on dialysis, we give IV iron every month, and we try and maintain the the maintenance dose that is required. So everyone, in fact, we give free iron to all our patients. So what do you think this can have a toxic effect on the endothelium? Of course, we also think that there may be a bacterial, infection-related issue in some of these patients as well when they are overloaded with iron. So, so what are your comments on this?
One of my PGs actually measured an area under curve of catalytic iron done every hour after the injection of iron sucrose. In a dose-dependent manner, the catalytic iron goes up for the first 6 hours, and then the body's chelating mechanism. See, anytime a free iron is in the blood, it will be taken up by transferrin and doesn't remain catalytic for some time. But so if you measure the baseline, you got a dose-dependent area under curve of catalytic iron that happens till first 96 hours after giving. Whether this translates to a clinically recognizable injury is not clear. Now, in the dogs, what we did was we tried to inject radio contrast after dehydrating them. I measured catalytic iron, as well as we measured the urinary enzyme excretion. Urinary NGAL, NAG, AAP, and alkaline phosphatase. And we showed about 100% increase in catalytic iron and 100% increase in these enzymes, even if the creatinine did not change. So if you looked at early markers of injury, it may not be clinically significant at that point of time. If you looked at that slide that I brought out, that if you looked at timed average constant of catalytic iron in maintenance hemodialysis population, those who have higher catalytic iron have lower event-free survival. So now what can be done? We could design a study where into these critically ill patients, you can give an iron chelator and see whether it produces patient benefit in terms of mortality, morbidity, and things like that. Once a study was completed between me and Professor David Leaf, where we called that study a defeat AKI in patients undergoing coronary artery procedure. To give deferoxamine just prior to contrast injection day 2
Yes.
and day 3 and see if there was a
Yes.
reduction in the production of AKI.
Yes.
We got the samples from Boston, where
Yeah.
this is a 6 or 7 center study. Now it's still under with the statisticians to find the results. Now one could consider using
Yes.
deferriprone, which is an ion chelator, in situations like, say, ICU, where the catalytic ion is very high, and block it to see whether you reduce the ICU mortality or occurrence of AKI in ICU. That could be a study. But as I said, I ran out of money.
Yeah.
But
Yeah.
you can build on this. This method is no more patent protected and is published in the Annals of Clinical Biochemistry. And if any one of you want to set it up, I'll be very happy to help his lab to set it up. And giving, if you took ferric chloride, say for example, you dissolved ferric chloride in sterile water, plain ferric chloride, and injected it IV in an animal, he will just die of oxidation. Therefore, when you give iron also, all these are iron sucrose complex, where iron is in the center. And there is so that is how biology protects iron from being exposed to. Even then, I have shown that injection of iron sucrose does lead to production of catalytic ion, but body's defense mechanism is to try and chelate any free ion that comes. Supposing there is an intravascular hemolysis. Now look at patients with hemolytic disorders like thalassemia major. Now, thalassemia major also has very high catalytic ion, and iron is deposited in liver, cornea, heart. And those patients who are not treated with ion chelators die young. That is well published. Now, in those times, the catalytic ion was not measured. Many of these studies are from Georgios Kontagiorgis from Cyprus.
Okay. Yeah. So, considering the same thing, now we do have many preparations of IV iron. Now, iron sucrose, iron maltose, isomaltose, and isomaltose we give almost up to 2 grams one shot.
I'm scared. I'm scared of using.
That is the thing. Yes. Which one would you? What is your protocol for use of iron, sir?
I never gave more than 100 milligrams at a time.
Okay. Right. Yeah.
And it gave me more time to talk to the patients, let them come back again.
Yeah.
At least not more than twice a week is what, because they are going to be benefited in terms of increase in hemoglobin if they were relatively or truly oxygen. Hemoglobin was the problem. But the reason why you don't give iron while the patient has active infection is it will flare up infection, because bacteria and viruses also need iron for survival. They have a specific iron absorber or transporter on their cell membrane. These are called siderophores, and they have a higher affinity than transferrin. So therefore, if you have sepsis and you give iron, you get much more worse outcomes. So the analogy is there.
Yes.
Now, hepcidin binds iron and doesn't release it from macrophage, and that's a protective mechanism against sepsis.
And so a combination of oral against IV iron, because IV iron you're giving a large dose and the potential of catalytic iron is high, whereas oral iron it's slowly absorbed, so the potential is lower. So is there a role for giving a regular oral iron and supplementing IV iron to probably a lesser extent? I don't know. I don't know about studies or anything like that, but
the problem with oral iron is that in those conditions where you have got high hepcidin, like chronic inflammation, like CKD, for example. The hepcidin blocks the DMT and helps prevents iron to be absorbed. So that is what should I say? A maladaptation that way.
Okay. Yeah.
So giving oral does not serve your purpose.
Okay.
But I'm against those who keep on trying to do more for patient convenience and doctor convenience, larger and larger doses of iron. These patients have to come to you and me all their life. Why can we not give it slowly and comfortably?
Thank you very much, sir.
There was a study from Taiwan, I think, where they used monthly EDTA injections in CKD patients and showed
Yeah.
that the slope of GFR flattens out. And they thought it is because they're chelating lead.
Okay.
But I and Dr. Sudhir Shah think that it was catalytic ion that they were suppressing by EDTA. So one could consider EDTA also as one of the things that one could use. They showed flattening of the slope of GFR in CKD patients. So we wrote a letter to the editors stating and giving our reasons why we think that it must be the iron that got chelated rather than lead. EDTA is a gross chelator of metals for many. They're used for lead toxicity, but it's not lead which causes renal worsening. Whereas there's no way in which you can excrete lead. And therefore, in renal failure, even small amounts of lead remains in the body. One of the common lead sources in India is the sindoor.
Yes, okay. That's very commonly used, yes.
Yes.
Thank you very much, sir.
I'm happy to answer any questions.
Yes, sir. There's one
willing
in the
to
chat.
Take criticism also.
One more last one is the testing. How is it difficult to set up a testing, components for catalytic ion, and what it is very cost? Is it costly? How do one set up a testing facility here?
I have published it in the Annals of Clinical Biochemistry. If you send an email to me, I'll send the article where we have described the whole method. And while doing that also, if you want to come back and talk to me, I'll walk you through that. Now, in Indian rupees, cost per test was 450 rupees.
My God, very reasonable. It's very doable, Wonderful. Thank you. Thank you very much, sir. Thank you.
Thank you.
Thank you, Dr. Lloyd. You actually just helped ask the question that I was about to. There is a question in the chat box, sir. It is from Douglas, and there are a number of IV iron preparations on the market. And do you have any preference, and why?
Well, I know clearly that catalytic ion gets released. I know clearly high catalytic ion is associated with adverse outcomes. But I also know that whenever free ion is generated by giving IV ion preparation, because the shell is not very correct. See, like if you see the ion preparations that came in the market right from the beginning, first thing came as Jectofer. I don't know, some of you may not have ever heard, or that was a very poor combination, and there were a lot of side effects. Acute yellow atrophy of liver was documented, particularly in those days when, in my residency times, they had brought a total dose of iron to be given IV as Jectofer. I think that was a combination of iron maltose, and about that led to a small percentage who died and also had acute yellow atrophy. I think retrospectively that must have been because of the catalytic ion. That time we thought that was a toxicity of that particular injection. Now, but as time went, more and more chelates of iron came. Iron sucrose, iron maltose, ferrocarboxymaltose, and so on. Now, better the shell you have on the iron, you have lesser generation of catalytic ion. So I don't have particular preference, but I'm scared of using a large dose in one go, because in the study that we did only with iron sucrose, I did not do studies with the other molecules which came later on, that a dose-dependent increase in the area under the curve of catalytic ion, when we measured it, it showed that catalytic ion is generated. But by 96 hours, the catalytic ion returns back to the normal level or the pre-exposure level in these patients. So I personally used to use iron sucrose, and never more than twice a week. That is what I used to do. My colleagues did use the newer molecules, but I used to be rather conservative about that, because I don't think it really makes that big a difference if you build up the hemoglobin gradually rather than you want the whole dose given one. And why do you want to give the whole dose in one go? It's probably because it's convenient to you and to the patient probably. And because it hasn't produced clinically significant problems like I've told you in my residency with Jectofor, or Imferon was the other trade name for iron. Therefore, you people think that it is easy, but I would be skeptical about that. And if you try to do a study, no iron making company will allow you to do it and won't fund it to you. Have I made myself clear?
Yes, sir, certainly.
Yes, sir.
Okay.
So while we're waiting for some more questions, I'd just like to point out that Dr. Yuri has shared the link for claiming the CPD points for Tanzania and Kenya. So please use the link to access the Google form that will help you get your CPD points.
Actually, Dr. Amar, there are two questions on the Q&A chat box. Maybe I can read the first one.
Oh, yes.
By
Yes.
Dr. Faustin.
Yes.
First question is, after acute MI, how long does it take for the serum catalytic ion to raise and being significant for acute coronary syndrome diagnosis? And do you have a value for this?
0.3 micromoles per liter is the significant value, and it remains like that. But in those patients where it continues to rise in the first 48 hours, then you have much more problem. Usually by third or fourth day, in those patients who are surviving, the value is returned back to the pre-infarction stage.
Thank you for that answer. I think the second question, you had already answered it, but let me just read it again. The question is, in dialysis patients who frequently receive IV iron, could iron therapy influence catalytic ion levels and potentially confound its association with cardiovascular disease?
Yes, that is correct. But keeping low hemoglobin also has poor cardiac outcome. So you need to meet hemoglobin targets, but in my opinion, they don't have to be met very rapidly. And their rapid rise in hemoglobin has also shown to be detrimental. So there really is no need to give one dose or large dose of iron at one time. So I personally would, in patients on hemodialysis, after their iron replete and their hemoglobin comes to about 10, try to give it once a month.
One last question, sir.
Yes.
How can we actually prevent this rise of catalytic ion as a prophylactic measure? Is there any way that we can do something to prevent this rise of catalytic ion? Yeah, in our CKD patient, of course, like giving IV iron does produce, but is there any sort of thing that we can do?
No, keep your patient well hydrated. So if the patient is well hydrated, your chances of getting AKI is low.
Yeah.
So therefore, when you produce animal models of AKI, due to whatever toxicity, you have got high catalytic ion. And for you to have a successful model of AKI, you need to dehydrate them.
Okay. Right. Okay.
So keep the patient well hydrated. It's standard teaching. For catalytic ion itself, you can't do really much, but you can treat it with ion chelators. Though as of today, there is no clinical evidence of a successful trial. The one I told you is still undergoing analysis of the results.
Okay.
Thank you, sir. I know it's quite late for you there, almost 11 p.m., so we won't keep you for very long. I just want to tell you that I'm really excited that you have also agreed to do a second talk later this year. So I will definitely reach out to you and we can plan the further details. So thank you so much, sir. It was a pleasure having you. And we've learned a lot, as we always do from you. Thank you so much.
Thank you. Thank you very much for having me.
Thank you, sir. Thank you very, very much. It was a wonderful session, a great eye-opener, for us in Africa, who are not been really doing much reading now, but, and there's a lot of...
I would say if you have a good idea, there's no reason why Indians, Africans, and anybody interested cannot do research. And we can do research as well as any Westerner.
Yes, absolutely. I agree, sir. I completely agree.
Thank you. Thank you very much.
Thank you very, very much.